Welcome back to the Deep Dive. This is the show where we take incredibly dense, highly technical source material, the kind of scripts that specialists train with, and we break it all down to find the critical, need-to-know information.
Today, we're tackling a subject in surgical oncology that's extremely challenging in its management, carcinoma penis. Our source is an MCH-level teaching script, so you know it's the highest standard.
That means it's rigorous.
It is. And our job here is to cover every single point. Diagnosis, staging, the complex treatment pathways, all with absolute clinical precision and detail.
Exactly. This is a very deep analysis of a foundational document. Now, before we get started, it's mandatory that we clearly state the author and credentials for the script we're using.
Of course.
The source material for today's deep dive was authored by Dr. Senthil Kumaran. He is an associate professor in the Department of Surgery at AIIMS, Nagpur, in Maharashtra, India.
And his qualifications are quite impressive.
They are. His qualifications are MBBS from Jitendra, Pondicherry, and MS in General Surgery from NP Dimer, Chandigarh.
Those credentials really confirm the authority and the depth of the clinical knowledge we're about to explore.
Absolutely. And here's what makes this topic so immediately relevant. You might think of this as a rare cancer, but the material points to a really shocking public health truth.
That it's largely preventable.
Exactly. The key factors are things like basic hygiene and circumcision. I mean, they're so simple. But when you have a cancer that can be so devastating once it spreads, and its roots are tied to these preventable factors, the stakes just become enormous.
It forces you to look at it differently, not just as a surgeon, but through a public health lens. The disparities you see around the world really highlight some fundamental gaps in preventative medicine.
Okay, let's unpack this. Let's start with the basics. We need to set the foundation, define this malignancy and its context.
At its core, it's defined as a malignancy that arises from the penile epithelium. But the really defining characteristic, the one that shapes the entire management pathway, is the histology.
What the cells actually look like under a microscope.
Precisely. And the script is very clear. Over 95% of these cases are squamous cell carcinoma, SCC.
So that overwhelming majority means that anytime a patient presents, you're almost always starting with the SCC management pathway in mind.
Unless it's proven otherwise, yes, that's your default.
Yeah, we touched on this, but where is this cancer actually seen most often? What's the context?
It's most common in regions, well, a combination of low hygiene standards and a low rate of circumcision.
So there's a direct link.
A very direct correlation. The data links cultural practices around hygiene, or lack thereof, and the absence of neonatal circumcision with a much higher frequency of this cancer.
And the reverse is true.
The reverse is strikingly true. In populations where neonatal circumcision is routine, the incidence just plummets. It becomes almost zero. It's a very powerful epidemiological signal.
And what about the demographic? Who is the typical patient?
Well, it's a disease of cumulative risk. It takes time to develop. So the peak demographic is specified as men between 50 and 70 years old.
So middle-aged to elderly men.
That's who the surgical trainee should have in mind, yes.
All right, let's get into the etiology. The script calls this section high yield for academic exams, so we really need to dig in here. What is the single most significant predisposing factor?
Without a doubt, it's phimosis.
Phimosis, can you define that for us?
It's the inability to fully retract the foreskin back behind the glands. And it's so critical because it creates this closed, non-aerated environment. It's a trap for irritants.
It sets the stage.
It absolutely sets the stage for the chronic inflammatory cascade that's necessary for the cancer to develop.
And in that environment, what specific infectious agent is then able to thrive?
That would be the human papillomavirus, the oncogenic types, specifically HPV 16 and 18. The virus itself is quite common, but its ability to cause cancer is dramatically amplified when you combine it with the conditions created by phimosis.
Which links right back to hygiene. The script mentions smegma irritation. How does smegma contribute here?
So smegma is just an accumulation of exfoliated skin cells, oils, and moisture. When it's trapped by a phimotic foreskin, it can't be cleaned away. It stagnates. It becomes a chronic, low-grade irritant.
And that irritation triggers inflammation.
Exactly. The body is constantly trying to fight this irritation, which leads to continuous cellular turnover and local damage to the epithelium. And as you know in oncology, chronic damage is the soil where cancer often takes root.
The script also points to other chronic inflammatory conditions as precursors.
Yes, specifically balanitis serotica obliterans, or BXO. It's a condition similar to lichen sclerosis that causes severe scarring.
And that scarring can lead to phimosis itself, right?
often leads to a secondary phimosis and also medial stenosis, which is a narrowing of the urethral opening. Really, any condition that creates long-standing inflammation and mechanical restriction is going to heighten the risk.
And what about other factors?
We also have to list smoking. It's a general oncogenic factor that affects epithelial tissues all over the body, and that includes the penis.
So we have the mechanical factor, phimosis, and the infectious agent, HPV. The script puts it together in this perfect, concise analogy. It says, phimosis plus HPV, penile cancer pathway. Can you walk us through the biology of why that equation is so deterministic?
It's really a perfect storm of biology and environment. The phimosis creates a protected niche, it reduces oxygen exposure, and it prevents natural cleansing.
So irritants and the virus can concentrate there.
Right. And this keeps the epithelial cells in a constant state of repair and regeneration. This dysfunctional cycle, which we call dysplasia, makes the cells far more vulnerable. So when high-risk HPV types 16 and 18 infect these already damaged cells, their DNA gets integrated.
And the virus takes over the cell's machinery.
It does. The viral oncogenes E6 and E7 go to work. E6 degrades the p53 protein, and E7 inactivates the RB protein.
Which are the cell's natural tumor suppressors, the brakes.
Exactly. Without those breaks, the epithelial cells are just driven towards malignant transformation. That's why having both the environment phimosis and the driver HPV creates such a powerful synergistic pathway straight to squamous cell carcinoma.
That mechanism really sets the stage. Now, before the disease becomes a full-blown invasive cancer, it often shows up as these precursor lesions.
And understanding these early stages is critical. It's the surgeon's opportunity to intervene, to cure the patient without compromising function.
The main term for these early changes is PI.
Yes, PIN, which stands for penile intraepithelial neoplasia. It's the umbrella term.
Okay, so let's break down the different types of PI, because the script distinguishes them based on where they are and what they look like. Let's start with carcinoma in situ, or CIS.
Right. And with CIS, we have to be very specific about the anatomical location. When we say CIS, or its other name, Bowen disease, we're typically talking about a lesion on the skin of the penile shaft, a non-mucosal surface.
And what does it look like?
It usually presents as a single, reddish, scaly plaque. The key thing about CIS is that the abnormal cells haven't invaded past the basement membrane yet. They're still contained.
And what if that exact same pathology is found on the glands?
Then it gets a different name. It's called erythroplasia of Queyrat. Histologically, it's identical to Bowen disease. The cells are the same, but because it's on the mucosal surface of the glands or the prepuce, it looks different. It's often a shiny, velvety red plaque.
So the distinction is clinical, not biological.
Primarily, yes. The biological risk of it progressing to invasive cancer is the same.
And there's a third type mentioned, Bowenoid papulosis.
Right. Bowenoid papulosis is different in that it presents as multiple smaller papules. They're often reddish-brown or even purple, and you typically see this in younger patients.
Is it also linked to HPV?
Very strongly linked to HPV, and while it can sometimes regress spontaneously, it's still an intraepithelial neoplasia. It needs to be treated or at least watched very closely.
Okay, so if we're lucky enough to catch the disease at this superficial, non-invasive stage, what are the management options?
The goal here is maximum preservation. So for small lesions, the first line is often topical therapy.
What agents are used?
The two main ones are 5-fluorouracil, or 5-FU, which is a topical chemotherapy, and imiquimod, which is an immune response modifier. It stimulates the body's own immune system to attack the abnormal cells.
And these work because the disease is just on the surface.
Exactly. But if topical therapy fails, or if the lesion is a bit deeper, we have to escalate.
What's the next step up?
That would be laser ablation, usually with a CO2 laser. It allows for very precise destruction of the abnormal tissue with minimal damage to the underlying structures. The cosmetic and functional outcomes are usually excellent.
But there's a downside to ablation, isn't there?
There is. You destroy the tissue, which means you can't examine the margins microscopically, so you have to be absolutely certain that you're only dealing with superficial disease where there's no early invasion.
And what's the final definitive surgical option for a precursor lesion?
If the lesion is very extensive or it persists after other therapies, the definitive treatment is a glandsectomy.
Which is the surgical removal of the entire glands.
Yes. It's a significant procedure, of course, but it ensures complete oncological clearance before invasion can happen, and it still saves the corpora cavernosa and most of the penile shaft.
Okay, let's pivot now to the definitive pathology. We know 95% is SCC, but the script details 4 key subtypes: Why is it so critical to identify which subtype we're dealing with?
Because of their behavior. The grade and the architecture of the cancer tell you how aggressive it's going to be, and critically, its likelihood of spreading to the lymph nodes.
So beyond the usual type SEC, what are the variants we need to know?
There are three key ones to focus on.
Let's start with the most aggressive types.
Okay, the first is the bacilloid subtype. This one is really important. It has a very strong link to high-risk HPV, and clinically, it's known to be much more aggressive than the usual type.
What does that mean in practical terms?
It means it has a higher rate of nodal metastasis. That forces you to be much more aggressive in managing the lymph nodes, even if the primary tumor is small.
And then there's one that mimics a completely different type of cancer.
That's the sarcomatoid subtype. It's the rarest, and it's characterized by these spindle-shaped cells that make it look like a sarcoma.
And its behavior?
It's extremely aggressive. It tends to metastasize early and widely. It carries the worst prognosis of all the subtypes. Identifying it immediately signals that you're probably going to need systemic chemotherapy and very expensive local clearance.
So those are the highly aggressive ones. But then there's an exception, one that behaves very differently.
Yes, the verrucous carcinoma. This one is, it's the outlier. It's characterized by this warty, outward-growing appearance. It can get very large locally, very destructive.
But it doesn't spread.
It has a remarkably low propensity for metastasis. It's a low-grade biology.
So if you know you're dealing with a verrucous type, does that change the entire surgical strategy?
It changes everything. For verrucous carcinoma, your main concern is the local bulk. You need a wide local excision, maybe a partial penectomy, to get clear margins. But because the nodal risk is so incredibly low, you can often avoid the high morbidity inguinal lymph node dissection.
A perfect example of pathology dictating the surgery.
Absolutely.
Okay, so let's follow the path of the cancer. How does it spread, starting locally?
The local infiltration follows the anatomy. It starts in the epithelium, moves down through the lamina propria, and then into the erectile tissues.
The corpora.
The corpora spongiosum, which contains the urethra, and then the deeper corpora cavernosa. The depth of that invasion is what determines the T stage. If it keeps going, it can invade the skin, the urethra, and eventually the scrotum or pelvic bones.
And where does it go first when it decides to spread further?
The primary route is lymphatic spread. This is the single most critical prognostic factor. The lymphatic drainage of the penis is very specific. It flows first to the inguinal nodes in the groin.
So that's almost always the first stop.
Almost certainly. If the cancer is going to spread regionally, it will land there first.
And what about spread to distant organs?
That's hematogenous spread through the bloodstream. The source is clear that this is a feature of late-stage disease. This would be spread to places like the lungs, liver, or bone. At that point, the disease is systemic and management shifts towards palliative care.
Now let's put on our clinical hat. The patient walks into the clinic. What's the typical picture? Where does the cancer usually start?
The location hierarchy is pretty consistent. The most common site is the glans, followed by the prepuce or foreskin, and it's least common on the shaft. The glans really bears the brunt of the risk.
And what does it actually look like?
It's usually not subtle. You're looking for one of three things. An ulcer, which is a non-healing sore, an exophytic growth, like a bulky mass, or sometimes just a warty lesion.
And the symptoms?
The associated symptoms are often what bring the patient in. Things like bleeding, a persistent discharge, and often a very severe foul smell, which is usually due to secondary infection and necrosis within the tumor.
That foul smell leads us right to what you call the nodal dilemma. This is a huge diagnostic challenge.
It's where surgical judgment is really put to the test. A patient comes in with palpable, painful lymph nodes in the groin. The stakes are huge. You have to ask, is this just secondary infection draining from that foul-smelling ulcer? Is it reactive lymphadenitis?
Or is it metastasis?
Or is it true, ominous metastasis? And making the wrong call operating unnecessarily or, much worse, delaying cancer treatment can be catastrophic.
Here's where it gets really interesting for the clinician trying to make that call. What's the absolute golden rule when faced with this kind of uncertainty?
The rule is simple and unequivocal. In any non-healing lesion on penis biopsy, there's no scenario where you just watch a persistent penile lesion. You have to get tissue. Delaying the biopsy is delaying a potentially life-saving diagnosis.
Okay, let's walk through the diagnostic process step by step, starting with the physical exam.
The exam has to be meticulous, and the first step is non-negotiable. The foreskin must be retracted. If the patient has phimosis and you can't retract it, the script implies you may need to do a dorsal slit under local anesthesia. You can't stage a tumor you can't fully see.
What specific details need to be documented during that exam?
Everything. The size, the site, the extent of the lesion. Crucially, you have to assess invasion into the corpora. You need to feel if the erectile bodies are fixed to the tumor. You need to check for meatal or urethral involvement.
Because that determines the type of surgery.
It determines if the patient can have a partial or needs a total penectomy. And finally, you have to palpate the inguinal nodes. Note their size, their tenderness, and critically, their mobility. Are they mobile or are they fixed?
Mobile suggests reactive, fixed suggests something worse.
Exactly. Fixed nodes are highly suggestive of extracapsular spread and advanced disease.
All right, exam is done. We need tissue. What kind of biopsy is required?
The script mandates an incisional biopsy for all lesions. A simple punch biopsy isn't enough. You need to take a wedge of tissue that includes the surface and the underlying layers so the pathologist can accurately assess the depth of invasion and look for high-risk features like LVI.
After the biopsy confirms cancer, we move to imaging for staging. What are the key modalities?
The imaging is tailored to the question you're asking. For local staging of the primary tumor, the best tool is an MRI of the penis.
Why MRI over CT?
Superior soft tissue contrast. It gives you exquisite detail on the depth of invasion into the corpora cavernosa and spongiosum. And it's essential for confirming urethral invasion. It's the roadmap for the surgery.
And what about for staging the regional nodes?
For that, we use a CT of the abdomen and pelvis. This lets us look for any pathologically enlarged nodes in the inguinal basins and the deeper pelvic nodes.
And when is a PT-CT used?
PT-CT is reserved for high-stage disease assessment. You'd use it if you suspect distant metastasis, M1 disease, based on symptoms or very aggressive local features.
Finally, what about the mandatory lab work? The script specifies testing for HBsAg, HCV, and HIV. Why is that required for every patient?
It's about risk factor overlap and treatment planning. HPV, HIV, and hepatitis often share similar exposure contexts. More importantly, if a patient is immunosuppressed, say from untreated HIV, it can dramatically accelerate the progression of their HPV-related cancer.
And it affects their ability to tolerate treatment.
Absolutely. You need to know their overall health and immune status before you can even consider putting them through an aggressive chemotherapy regimen like TP. These labs are a crucial part of the pre-treatment workup.
Okay, now we're moving into the most technical but arguably the most critical section for any trainee, the 8th AJCC TNM staging system.
This is the foundation for everything that comes next. Every treatment decision, every prognostic discussion, it all comes from this. Precision here is paramount.
Let's break down the T category first. The local tumor extent, the depth of invasion.
The T stage dictates the local surgery. So we start with TIS. This is the non-invasive stage. PIN, carcinoma in situ. The tumor is confined to the epithelium.
Then we get to T1.
T1 is invasion into the subepithelial connective tissue, the lamina propria, but T1 is immediately split into two groups based on biological aggression.
And this distinction between T1A and T1B seems to be where the entire prognosis can pivot.
It's a massive turning point. So T1A is lamina propria invasion, but the tumor is low grade, and critically, it lacks lymphovascular invasion, or LVI. This is the favorable T1.
Often managed with organ-sparing surgery.
Correct. But T1B is the high-risk T1. It's still just in the lamina propria, but the tumor is either high grade or it has LVI.
Let's pause on LVI. It's a microscopic finding, but it has these huge clinical implications.
Yeah.
What is the pathologist seeing, and why does it change a patient's fate so dramatically?
When the pathologist reports LVI, it means they can see malignant cells inside the lumen of lymphatic channels or small blood vessels right at the edge of the tumor. For the cancer, this is like finding the on-ramp to the superhighway.
It has a way out.
It has a means of rapid transport away from the primary site. The moment LVI is confirmed, even a physically tiny T1B lesion is behaving biologically like a much more advanced cancer. The risk of occult, non-palpable nodal metastasis just skyrockets.
From what to what?
It goes from less than 10% in a T1A to well over 30 or 40% in a T1B. This one microscopic detail forces the surgeon to immediately shift from a conservative watch-and-wait approach to a very aggressive management of the inguinal nodes.
That's a huge shift.
Yeah.
Okay, so moving past T1 invasion, what is T2?
T2 means deeper invasion. It's entry into the corpus spongiosum, or direct invasion of the urethra.
And T3?
T3 is invasion into the deepest erectile structures, the corpus cavernosum. T3 is a major demarcation point because once the corpora cavernosa are involved, it usually compromises the structural integrity of the organ, often meaning a total penectomy is needed.
And finally, T4?
T4 is the most extensive local stage. It's invasion into adjacent structures like the pubic bone, the prostate, or the scrotum.
All right, now for the N category, nodal status. The script calls it the destiny decider.
And it's not an exaggeration. It is the single most powerful prognostic variable we have.
So what are the stages?
N1 indicates involvement of a single inguinal node, the earliest clinical metastasis. N2 means involvement of multiple inguinal nodes or bilateral nodes. The more nodes are positive, the worse the outlook.
And N3 is the most concerning.
N3 is the most concerning regional stage. It's reserved for two situations, either involvement of the deeper pelvic nodes or evidence of extracapsular spread in the inguinal nodes.
Let's focus on that extracapsular spread. Why is that so significant? It means the tumor has broken out of the node itself.
Exactly. The tumor cells have burst through the fibrous capsule of the lymph node and are now in the surrounding fat and connective tissue. This makes getting a clean surgical margin during dissection almost impossible, and it signals a highly aggressive biology. N3 disease is a systemic threat.
And finally, the M stage.
M is straightforward. M0 is no distant metastasis. M1 is the presence of distant spread to sites like the lungs or bone, which automatically shifts the patient into a palliative treatment pathway.
Okay, now we can move to the core of the script, treatment. And the guiding philosophy seems to be this dual focus, oncological control plus organ preservation.
That's the art of it. You have to achieve a cure, but you also have to maximize the patient's quality of life after treatment. And the extent of that surgery is rigidly dictated by the T stage we just discussed.
So let's detail the options, starting with the earliest stages, TIS and T1A.
For TIS and T1A, we prioritize preservation. We can use topical therapy, laser ablation, wide local excision, or a simple circumcision if the lesion is just on the prepuce. The goal is to avoid major amputation.
But then we get to T1B and T2 where the risk is higher.
For T1B and T2, the surgical intervention is non-negotiable. This requires either a glanectomy or a partial penectomy. And the absolute mandate here, which the script emphasizes, is a 2-centimeter mandatory margin.
2 centimeters. That sounds like a lot in such a small, functionally critical area.
It is the cornerstone of local control. It often means taking more tissue than you think you need because a local recurrence is catastrophic. The challenge is getting that 2-centimeter margin while still leaving enough healthy shaft to create a functional neometus, a new urethral opening.
And if the remaining penis is too short.
If it's less than 3 centimeters, the patient may not be able to direct their urinary stream. And that often pushes the surgeon towards a total penectomy, even if a partial resection was technically possible.
Which brings us to the advanced stages, T3 and T4.
For T3 and T4, preservation is usually off the table. It's no longer oncologically viable. These stages require a total penectomy combined with a perineal urethrostomy.
Can you walk us through what a perineal urethrostomy means for the patient functionally?
A total penectomy removes the entire external shaft. The urethrostomy reroutes the remaining urethra to a new opening in the perineum, the area in front of the anus. This means the patient will have to urinate in a seated position for the rest of their life.
It's a profound change.
It's a profound functional and psychological change, but it is the necessary price for a cure in advanced disease.
And if the tumor has specifically invaded the urinary tract?
If there's urethral involvement, then a urethrectomy, removal of the entire urethra, is required to ensure all the malignant tissue is cleared.
Let's circle back to those more delicate preservation techniques like Mohs surgery and glands resurfacing. When are they actually safe to use?
They are only applicable for the most superficial, low-risk lesions, strictly TIS and T1A. Mohs surgery involves taking sequential thin layers and checking the margins as you go.
So you stop as soon as it's clear.
Exactly, which offers maximum tissue preservation. Glands resurfacing is basically a skin graft after the diseased epithelium is removed, but the risk is under treatment. If you miss microscopic LVI or a deeper focus of invasion, the chance for an early cure is lost, so patient selection has to be incredibly strict.
Okay, let's move to what you've called the most important part, inguinal node management, the prognostic imperative.
We have to keep reiterating this. The nodes determine destiny. Managing the inguinal nodes is the most significant factor in determining a patient's prognosis.
So let's resolve that nodal dilemma we talked about earlier. The patient has mobile, tender nodes. What is the mandatory first step?
The antibiotic trial. It is mandatory. The patient gets broad-spectrum antibiotics for 4 to 6 weeks. We are testing the hypothesis that the palpable node is just reactive lymphadenitis from infection.
And if the nodes completely resolve after those 4 to 6 weeks?
We can assume they were reactive, but if they persist, we have to assume metastasis until proven otherwise.
And then we escalate to surgery.
Correct. We would then proceed to either a DSNB, a dynamic sentinel node biopsy, or a full ILND, an inguinal lymph node dissection.
Can you explain the difference in morbidity between those two? Why try to avoid a full ILND if you can?
A full ILND is a major operation. The most significant long-term complication is lymphedema, which is severe, chronic swelling of the leg because you've disrupted the lymphatic drainage. There are also high rates of wound breakdown and infection. DSNB, by just removing the 1 or 2 sentinel nodes, radically reduces that morbidity.
As long as those nodes are negative.
As long as they're negative.
So let's look at management based on the clinical nodal stage. What about the patient with no palpable nodes but a high-risk primary tumor, like a T1B with LVI?
That's the CN0 high-risk primary patient. They have no palpable disease, but the pathology is telling you this cancer is aggressive. The risk of microscopic nodal disease is too high to just watch and wait.
So you have to intervene prophylactically.
Yes. They require either a DSNB to sample the nodes or sometimes a prophylactic limited ILND. The teaching pearl is that early ILND improves survival.
What about the patients where we strongly suspect metastasis, the nodes that persisted after antibiotics?
If the nodes are palpable and mobile, that's CN12 mobile, they proceed directly to a therapeutic ILND. The surgery here is meant to be curative to remove known cancer.
And the most advanced regional disease, the fixed nodes?
Fixed nodes, or CN3 fixed, suggest deep invasive disease. For this, we have to use neoadjuvant therapy. The first step is neoadjuvant TIP chemotherapy, followed by the ILND.
Why do the chemo first in that CN3 scenario?
2 reasons. First, you test how sensitive the tumor is to systemic therapy. But more importantly, you need to shrink that large fixed tumor mass. By shrinking it away from vital structures, you convert a potentially unresectable situation into a manageable one, improving the chances of getting clean margins during the surgery.
And when does the surgeon need to extend the dissection even further up into the pelvis?
A pelvic lymph node dissection isn't routine. It's only done for patients with high-volume disease in the groin. The criteria are very specific.
What are they?
If pathology confirms 2 or more inguinal nodes are positive, or if extracapsular spread is confirmed in any of the inguinal nodes.
So that's the signal that the cancer has likely already moved to the next nodal stage.
Exactly. The need for a pelvic LND elevates the patient to the highest risk category and really worsens the prognosis.
All right, let's talk about what happens after the surgery. What's the role of adjuvant therapy?
Adjuvant therapy is for cleanup. It's to kill any residual microscopic disease. Radiation is typically used for patients with positive surgical margins or confirmed extracapsular extension. It sterilizes the area to reduce the risk of local recurrence.
And for systemic treatment, we mentioned the TIP regimen. Can you detail what's in that?
The standard regimen for advanced penile SCC is 2-IP, paclitaxel, ifosfamide, and cisplatin. It's a powerful combination. Paclitaxel stops cell division, ifosfamide damages the DNA, and cisplatin creates cross-links in the DNA, causing cell death. It's an aggressive regimen for an aggressive disease.
And for the patients who unfortunately present with M1 metastatic disease from the start?
At the M1 stage, the focus shifts entirely to palliative care, managing symptoms, controlling pain, and maximizing quality of life.
Now, what about long-term follow-up? The surveillance protocol. How often do these patients need to be seen?
The risk of recurrence is highest early on. So for the first 2 years, it's an intensive surveillance period. They need to be checked every 3 to 6 months.
And after that?
The frequency tapers off. It becomes every 6 to 12 months, up to 5 years. But even after that, they need to maintain lifelong hygiene and get HPV counseling. The risk factors never truly go away.
Let's revisit the prognosis data now. This is the ultimate proof of how important early detection and nodal management really are.
The numbers are stark, and they reflect the severity of nodal involvement perfectly.
So for a node-negative patient,
The outlook is excellent. 85 to 90% 5-year survival. If the disease is contained, it is highly curable.
and for an inguinal node-positive patient,
You see a precipitous drop. It falls to 40 to 50% 5-year survival. Just having regional spread cuts the survival rate in half.
and if it reaches the pelvic nodes.
Then the prognosis is very poor. It falls to less than 20% 5-year survival.
Wow. To see it drop from nearly 90% to less than 20, all based on how far the cancer has traveled through the lymphatics, it really drives home that conclusion from the script. Nodes decide destiny in cave penis.
It is the brutal reality of this disease. All the effort we put into precise T staging, the antibiotic trials, the prophylactic ILND, it's all justified by that catastrophic drop in survival once the cancer establishes regional control.
We started this whole deep dive by saying this is a preventable cancer. So let's end by reinforcing those core public health strategies. What are the 4 critical prevention points?
These are the tenets that, if we could apply them globally, would essentially eradicate this disease. 1, neonatal circumcision.
To remove the high-risk anatomical environment.
2, HPV vaccination. 3, smoking cessation.
Yeah.
And 4, simple penile hygiene education, which is often the lowest barrier but can have the highest impact in some settings.
Now for the MCH Viva teaching pearls, the actionable rules a surgeon must live by.
These are the 5 core concepts. First, biopsy first, never assume benign. Mobile tender nodes may be reactive. This is the justification for the mandatory antibiotic trial.
Third,
Early ILND improves survival, reinforcing that proactive approach for high-risk, clinically node-negative patients.
4,
Always assess corporal invasion for surgery planning. That finding, T3 disease, is what dictates the shift from a partial to a total penectomy.
and the last one.
Organ preservation whenever oncologically safe, a reminder to always balance the cure with the patient's quality of life.
Okay, let's bring this all together with the case vignette from the script. A 55-year-old uncircumcised male with a foul-smelling ulcer on his glands, phimosis, and palpable inguinal nodes.
This is the classic high-stakes presentation.
So question 1, what's the clinical staging here?
Well, clinically, we have a lesion on the gland, so it's likely a T1 or T2, and he has palpable nodes, so we're starting at least at CN1 or CN2. The final pathologic stage depends on the biopsy and the imaging, but right now we know we're dealing with regional nodal disease.
Question 2, how do you differentiate reactive versus metastatic nodes in this exact patient?
The mandatory 4 to 6 week antibiotic trial. We treat the obvious infection first. If the nodes resolve, they were likely reactive. If they persist after the full course of antibiotics, we stop observing and we proceed to DSNB or ILND. We cannot just assume it's infection.
And question 3, what's the comprehensive initial management plan?
It's multi-phased. Phase 1, biopsy the primary lesion to get the grade and LVI status. At the same time, you start the antibiotic trial for the nodes. Phase 2, you get an MRI of the penis to precisely stage the T category and determine if a partial penectomy is even feasible. The final surgical plan is only locked in after the antibiotic trial is done and the full staging picture is clear.
That entire process, from that initial clinical impression to the final treatment pathway, really captures the level of rigor this requires.
It does. It shows that this is a complex, sequential decision tree. It's not just about cutting.
And if we had to synthesize this entire deep dive into one final killer summary, it would be that line from the script.
It's the one that captures the entire story. Penis, HPV plus phimosis, SCC, early nodal spread, survival depends on ILND.
It covers the cause, the pathology, the spread, and the ultimate determinant of survival. A perfect summary. We've covered every mandatory point from this teaching script, etiology, staging, and the incredibly complex management of the nodes.
And the final thought I'd like to leave with you, the learner, has to be about prevention. We know this disease is preventable through things like HPV vaccination and neonatal circumcision. So the bigger question, the public health challenge, is this. What global strategies can we use to shift the cultural and economic barriers to effectively eradicate this disease so we can focus less on these complex and devastating surgeries?
That is a profound question to end on. Thank you for guiding us through this incredibly dense and important material. This deep dive was based entirely on the teaching script provided by Dr. Senthil Kumaran, Associate Professor, Department of Surgery, AIMS, Nagpur, Maharashtra, India. His qualifications are MBBS, JIPMER, Pondicherry, and MS General Surgery, PGIMER, Chandigarh. And thank you for joining us for the deep dive. We'll see you next time.